Order. Order. Jim Fitzpatrick to move the motion.
I beg to move that the House has considered early diagnosis and the cancer workforce in the NHS long-term plan, and I wish everyone a happy new year. I want to thank the Bank Vice President's Committee for supporting the bid of a number of colleagues for this debate, and to the Chairman of Ways and Means for allowing it. I was lucky enough to be drawn as the chief sponsor, but recognising the support that's here this morning, I will try and keep my remarks to 10 minutes or thereabouts. I'm grateful for the many briefings on this debate from the House of Commons Library, Bart's NHS Trust, Cancer Research UK, Breast Cancer Care, the Fire Brigade Union, Macmillan Cancer Support, Breast Cancer Now, Royal College of Pathologists, Maggie's, British Lung Foundation, Royal College of Physicians, Click Sargent, and the Royal College of Nurses. I think I've had more briefings from interested parties on this debate than for any other in my 21 years here, Mr Howarth. And interestingly, they virtually all agree on two basic points. One, they welcome the government addressing their issues in the 10-year review, and two, they welcome the new investment. But they ask for much more detail on staff, training, recruitment and retention. Mr Howarth, running through most of the briefings I received were questions about the publication of the NHS long-term plan promised by the end of 2018. In very timely fashion, the government published this yesterday. This has helped provide a better focus for this debate, but hasn't eliminated the need for it. On the briefings I've received, I wish to mention some of the issues covered. The Royal College of Pathologists raised some disturbing statistics, notably that just 3% of services reported they had enough staff to meet clinical needs, and that over three-quarters of departments reported vacancies for consultants. Their key messages were to emphasise the need for early diagnosis and call for increased investment in pathology services, particularly in the recruitment of training of pathologists and scientists, and that histopathology should be listed on the shortage occupation list as there is a shortfall of the speciality. No pathology specialities are currently included on the shortage occupation list by the Migration Advisory Committee. Placing histopathology on this list would assist overseas qualified pathologists in obtaining a visa to work in the UK. I'm very happy to give way to my honourable friend from Mugmer.
I'm very grateful to my honourable friend for giving way, and I should say that I lost my bowel cancer last year and have been campaigning on reducing the bowel cancer screening age to 50. In respect of pathology, though, what I gathered from that campaign, the debates I had on that, is it's so important that we get pathology capacity right. Otherwise, that reduction of the screening age isn't going to work. We need the pathology capacity around it as well. Does he agree that that is the case?
I certainly do. I'm sorry to hear about my honourable friend's mortality in his family, and certainly I'm sure the Minister will report on it. I will certainly be covering a little bit later on, but without the staff and without the diagnosis and the pathology services, then obviously the reduction in age screening will be pointless. The Royal College also identified a growing demand for pathology services, with a 28% shortfall in staff predicted by 2021. Cancer Research UK say, as we all know, that an earlier cancer is diagnosed, the more likely it is to be treated successfully. The Labour government's initiative to reduce the time between an urgent GP referral to seeing a cancer consultant to 2 weeks was a success in ensuring swifter treatment, but 2018 marked the first year when this target was not met. And I'd be grateful if the Minister could respond on how the Government expects to address this slippage. Cancer Research UK add that they're expecting new cancer cases to reach 500,000 a year by 2035. Right now it's 350,000. With more cases and more thorough screening measures, our NHS is going to need more diagnostic and treatment staff. They highlight that the promise to produce a workforce implementation plan later in 2019, after the spending review, leaves the status of Health Education England's upcoming cancer workforce plan unclear. And perhaps the Minister could comment and give us more information on how the two initiatives relate to each other. Macmillan make the point that they have recognised and welcomed the focus on cancer within the NHS long-term plan, including the PM's commitment to radically improve early diagnosis. However, they have concerns that the long-term plan will not adequately address the immediate and long-term pressures facing the NHS cancer workforce. Macmillan is also asking when the workforce plan implementation plan can be expected this year. A note from the statement from the Health Secretary yesterday that he expected Baroness Dido Harding to report to him by the end of March. And I'd be grateful, therefore, if the Minister might confirm that we can expect publication of the workforce implementation plan by the summer this year. Breast Cancer Now make the point that only 18% of breast cancer screening units are adequately resourced with radiography staff in line with breast screening uptake in their area. In my own area of North East London, covered by Bart's NHS Trust, the NHS North East London Commissioning Alliance and the East London Health and Care Partnership, many of the points made by the national charities are apparent locally. They make their concerns clear, covering the basic issue that cancer outcomes in North East London are among the poorest in London and the country, and that presentation via the emergency route remains high there and is clearly associated with advanced cancer and low one-year survival rates. In my own borough of Tower Hamlets, people diagnosed with cancer had a one-year survival index 4% lower than England, and that diagnosis through the emergency route remains high. The local NHS, therefore, has plans to attack this with a new early diagnosis centre due to open in December this year, the introduction of multi-diagnostic clinics, which were first introduced in Denmark and supported here in pilot phase by Cancer Research UK, and new FIT testing for colorectal cancer in primary care from April this year. They plan a health and wellbeing school spread across the whole of North East London, including the principle of making every contact count. And finally, raising population awareness and screening initiatives, including placing staff to promote screening in GP practices, promoting text reminders for cervical cancer screening, video competitions for schools to promote vaccinations, prostate cancer targets, breast and bowel cancer target ads on Muslim TV channels, and reintroducing bowel screening reminder calling and other initiatives. The North East London NHS conclusions are relatively simple. Workforce is a key factor in delivering a faster diagnosis standard expected by 2020 and beyond. Earlier diagnosis of cancer needs a resilient and sustainable radiology, endoscopy and pathology workforce. High cost of living, lack of affordable housing and disparity in salary across London are barriers to recruitment, and a need to look at technology, AI and digital pathology and innovations in careers. Click Sergeant raised a specific question of the problems of diagnosing child cancer and repeat worryingly that over half of young people diagnosed visited their GPs with their parents at least 3 times before their cancer was actually diagnosed, which is a particular concern. Breast Cancer Care also raised the workforce plan, asking how the commitments of the current cancer strategy and ambition of the long-term plan will be met. The Royal College of Physicians tell me that in London in 2018, 27% of physician consultant posts advertised were not appointed to, and across the UK a total of 45% of advertised consultant posts went unfulfilled due to a lack of suitable applicants. The British Lung Foundation make 2 key points. Early diagnosis is essential. Almost half of lung cancers are diagnosed at stage 4, when survival rates are very poor, and that there is an urgent need to train and employ more NHS staff to diagnose lung cancer earlier. The Royal College of Nursing also states that in England there are nearly 41,000 vacant registered nursing posts in NHS, which they predict will increase to almost 48,000 by 2023 if the government don't take action. Points raised by the Commons Library briefing include that the Cancer Workforce Plan, devised in 2017, recommended that action is taken to ensure enough staff with the right skills are trained to deliver the cancer strategy by 2021. In November of last year, the highly respected Professor Sir Mike Richards, NHS England's Cancer Director, announced that cancer screening would be overhauled as part of the long-term plan. Sir Mike also announced the review team to assess current screening programmes with a report due in summer 2019 this year. And I asked the Minister whether Sir Mike's timetable of summer 2019 might coincide with publication of the Government's workforce plan. And finally on these comments, the Library states there is no measure of the total NHS cancer workforce, and I wonder if the Minister would comment on this anomaly. In conclusion, Mr Howarth, I'd be grateful if the Minister, in his or her wind-up, would address the fundamental issue raised across all the briefings, which now focuses on the workforce implementation plan, how it fits into the strategy, and when it can be expected. I look forward to the Minister's response. He's highly regarded in his position as Health Minister. I look forward to the front benches from the SNP and my honourable friend, the Shadow Health Minister, and her responses, and to comments from so many other colleagues who have attended this debate this morning. Thank you.
The question is that this House has considered early diagnosis and the cancer workforce in the NHS long-term plan. there's a lot of people, it is an important subject, and there are a lot of people signifying that they want to be called in this debate. So I'm not going to impose a time limit straight away. I'm just going to see how it goes. But if people cooperate, I'm sure we'll be able to get everybody else in. Tim Farron.
It's a pleasure to serve under your chairmanship, and my Happy New Year wishes to all of you, and congratulations to the member for Poplar and Canning Town for securing this debate. Incredibly important and very, very timely given the announcement of the NHS long-term plan yesterday. I want to restrict my remarks when it comes to the cancer workforce to the workforce and indeed the other issues relating to radiotherapy. 1 in 2 of us, sadly, at some point in our lives, will contract cancer, will have cancer of some form or other, and 1 in 2 of those with cancer will receive radiotherapy treatment. So 1 in 4 of us will need radiotherapy. There are, roughly speaking, 1,500 people making up the entire radiotherapy workforce of the United Kingdom. The clinicians, the medical physicists, the therapeutic radiographers. 1,500 people. In the plan that we're obviously digesting from yesterday, there are many interesting things in there that are worthy of remark, much to be welcomed, many questions that still remain unanswered. On this issue of radiotherapy, the focus on survival and early detection is clearly crucial. The United Kingdom is very, very low down the league table of European countries when it comes to early detection of cancers, and that's the chief reason why survival is so poor compared to other nations of similar levels of prosperity. And that is something which is tragic on a personal level and actually deeply humiliating on a national level. If the government is successful, if the National Health Service is successful, if we are successful at detecting earlier cancers at stage 1 and stage 2 and treating them effectively and curing them, given that radiotherapy is 8 times more likely to be curative than chemotherapy, given that already 50% of those with cancer are having radiotherapy, it stands to reason the need for capacity for radiotherapy will increase manyfold. Around the country at the moment, within England, I think I'm right in saying there's 52 centres with a number of other satellites as well. There is nothing in this plan that scopes forward how the National Health Service will cope with the additional work that will be required if early diagnosis is more successful. And if we're looking at workforce and workforce issues in particular, it's worth bearing in mind there is significant pressure as things stand. As I say, with a workforce of 1,500, there's 2 ways of looking at it. One is that is a very small and precious resource, and we need to protect it. It also reminds you, however, these are relatively small figures, and with a relatively small amount of investment, you can make a significant difference to increase that workforce. Relatively small numbers equals a huge percentage, equals an ability to tackle many more cancers, indeed to cure many of them as well. So I just want to focus very briefly on one particular profession within the radiotherapy workforce, and that is that of therapeutic radiographers. I don't know if the Chair is aware, but in this current academic year, there is a 50% drop in the applications to therapeutic radiography courses at the UK's universities. One of the leading universities had to cancel its entire intake altogether due to under-recruitment. And almost certainly, 99% certainly, the cause of this was the removal of the bursary from that particular programme. The standard applicant is a mature student who's choosing to do something different with their life, having done something else first, and it has a huge impact on those people. So if the Minister wanted to do something quickly to tackle that particular aspect of workforce, he could reinstate the bursary for radiographers. And I just throw that out there. As chair of the All-Party Radiotherapy Parliamentary Group, great to see one of our vice chairs here today, the member for Easington, many others as well. We had a really good meeting with the Minister at the end of November last year. Very grateful to him and his staff for their time and for their attention. And they have yet to respond, but I didn't expect them to in this time, to the manifesto we presented them with that day. But it calls for a number of things. It calls for new investment. It calls for more money. You'd be surprised if we didn't ask for that. But I just want to put that in context. The United Kingdom, as I say, half of those who have cancer will require radiotherapy, and yet only 5% of the cancer budget goes on radiotherapy. That compares very poorly with other countries. Australia, it's about 5%. The European average is something like 7 or 8%. So what we have proposed, cross-party, is the government invests 100 million every year into machine upgrade for the high-quality, targeted, stereotactic and other advanced forms of radiotherapy, a fund that can cover all the trusts, so they're not having to delve into their own reserves, and then a 250 million upfront one-off investment so that those people who live in communities like mine, who live an awful long way from the nearest treatment, can have a satellite unit developed close to them. So for us in South Lakeland, many of my constituents have to travel 3-4 hour round trips to get good treatment at Preston, but a very large percentage, maybe even up to 50% of those who could have radiotherapy in my constituency and in other parts of South Cumbria don't get it because they're considered to be too far away for it to be reasonable journey time. And given that radiotherapy is so often more curative than chemotherapy, ergo, there are people who are living less long because they live too far from treatment. That's why a radiotherapy centre, a satellite centre at the Westmorland General Hospital in Kendal is a key example of what we're talking about. But there'll be other places around the country where access is a problem, where travel times are a problem, and that's why investment in satellite units that don't necessarily involve that much more staffing, because with proper IT networking, you can be able to do many of these things by remote. I just want to conclude by saying this, and that is that the NHS plan that was announced yesterday had much in it that was interesting. When it came to radiotherapy, it was entirely a rehashing of things that we already knew. Things were welcome, but there was nothing new. And so I look forward to the government responding to its own consultation, which closed 12 months ago now, on radiotherapy, and I ask for an update on that. I also ask for the National Cancer Advisory Group's 2018 report to be released as soon as possible. And finally, very much look forward to the government's response to the all-party parliamentary group on radiotherapies manifesto, which was presented to it in November. Thank you.
Howard, for calling me to speak in this important debate. And I would like to congratulate my honourable friend, the member for Poplar and Limehouse, and I also would like to thank my right honourable friend, the member for Westmoreland and Lonsdale, who chairs the all-party group that I'm also a member of, which you referred to on their radiography. I don't want to repeat the arguments that have just been made, but there are some key threads that run through the whole of this debate. And although the title of the debate is Early Diagnosis and the Cancer Workforce in relation to the long-term plan, I think we have to marry some concepts here. Yes, early diagnosis is important, but that has to be married with a skilled and effective workforce and also the most effective treatment available. And I don't just mean available in our capital city, I mean across the whole of the country. So I want to kind of touch on that issue as well. I also have to declare an interest, Mr. Howarth. I'm a cancer survivor. I was successfully treated with both chemotherapy and radiotherapy thanks to a relatively early diagnosis. I'm vice chair of the all-party group on radiotherapy. But I'm not alone in having benefited from radiotherapy, as was mentioned earlier. During the course of our lifetimes, almost half of us will suffer from cancer at least once, and of those, about half will actually receive radiotherapy. I'm really concerned because, although I was very fortunate, and I count my lucky stars, I'm acutely aware that there are particular cancers, notably prostate cancer, notably pancreatic cancer, and a terrible story yesterday from the Honourable Member for Crawley of his caseworker who passed away as a consequence of pancreatic cancer, but also lung cancers and indeed breast cancer. For a modern industrial nation, our cancer outcomes are poor. They should be far better. So I hope that the 10-year forward plan that was published yesterday is an opportunity to address some of these really fundamental problems. And I do think it's really important we invest in modern, accessible cancer diagnosis and treatments. And I do want to refer to the long-term plan that the Prime Minister announced yesterday and on which we had a statement in the House of Commons. I particularly want to refer to Chapter 3 and 3.62 in particular on treatment and radiotherapy. I must confess, I was quite optimistic having met with the Minister, who I've known for some years, and I think is a decent and honourable individual and who was very positive in the meetings that we had, both he and his staff. And I was hoping, based on the evidence that was presented, we'd have a much more positive outcome from the 10-year plan. The government have promised to complete the £130 million investment in radiotherapy machines and to commission the proton machines. That's the 2 proton beam machines, one in Manchester at Christie Hospital and one in London at University College Hospital. But in all honesty, that isn't a new commitment. These machines are either already completed or almost completed. So it's kind of a recycling of an existing announcement. And what we actually need, Mr. Howarth, if we are going to have a step change, and if we are going to have a real world-class set of outcomes and a world-class cancer treatment service, we do need a modest increase, and it is a modest increase in relative terms, in advanced radiotherapy. And what we're asking for, and it's set out in the manifesto for radiotherapy, and I would recommend all members have a read of it, because if they're not affected themselves, certainly many of their constituents will be. And we're asking for an initial one-off investment of £250 million, and then an additional £100 million in each successive year. And part of that would go into workforce and running costs and so on. So I do think that even though in 50% of cancer cases radiotherapy is required, access is very patchy, and it varies from 25% to 49%. And the Right Honourable Member for Westmoreland and Lonsdale indicated, representing a rural area, the figures are really quite low. The average is about 38%. Ideally, according to Cancer Research UK, patients shouldn't have to travel more than 45 minutes to access this form of treatment. And if we are going to achieve that 45-minute access, it's going to require considerable investment. I don't think there's anything in the plan that's concrete. The Minister may be able to elaborate on it, that's going to address this very serious issue. Early diagnosis, I welcome the government's commitment there. It says they're going to increase the number of patients diagnosed with stage 1 and stage 2 cancer. They're going to increase the diagnosis by 25%. And in terms of lung cancer, they want to increase the diagnosis of stage 1 patients by 47%. But in practical terms, the government will need more advanced radiotherapy machines to ensure they can cure many of these stage 1 tumours. They will need additional radiotherapy machines to treat the stage 2 patients. So the government will need to rapidly expand the advanced radiotherapy facilities around the country. And the way to do that is set out in the manifesto, and that would achieve not just early diagnosis, but improved survival and outcomes. I'm very pleased. I want to give the Minister credit. He's looking a bit quizzically. I hadn't intended to beat him up. But we are trying to be helpful. I think the aspiration and the wish to improve cancer outcomes and see a first-class service is shared around the House. And I was very pleased that he's recognised the representations that were made in relation to hypofractionated treatments, and there was a perverse incentive. This is in relation to the tariff. So the government have said they're going to address that issue. I'd like some assurance that it will be addressed very quickly and not in 10 years' time, because the evidence is clear that it is working as a perverse incentive to or disincentive for the most appropriate form of treatment. I want to wind up, Mr. Howarth, because I know many people want to speak in this debate. But I am pleased the government have admitted and accept that advanced radiotherapy is effective and has fewer side effects. I do want to see a specification that comes out, and I do want to ensure that when it does come out, we won't see what effectively we have at the moment, which is the rationing of effective treatments. Specialists in the field have told me that the specification that's being discussed at the moment is essentially no different to the specification that was available a year ago. So I want to press the Minister to make a response to the submissions that we've made. I want to see an increase, a fairly modest increase in terms of the NHS budget and indeed the cancer budget, from the current 5% to 6.5% of spend on advanced radiotherapy. And I do think it would enable large numbers of cancer patients to live longer and more fulfilling lives and achieve better outcomes and achieve positive economic benefits. I commend it to the Minister, and I urge him to look at it as part of the ongoing cancer strategy and the NHS 10-year plan.
Thangam Debbonaire.
Thank you, Mr. Howarth, and it's a pleasure to serve under your chair. And also, I wish to thank my honourable friend, the member for Limehouse and Poplar and Limehouse, and other honourable members for their contributions. I want to focus particularly on cancer affecting children, teenagers and young adults. Other members will know that I have personal experience of another cancer, breast cancer, and there are many more expert people than me in the room who will talk about that. So I'm going to focus on the form of cancer for which I recently set up an all-party parliamentary group, which is that affecting children, teenagers and young adults. And the reason I did this is because each year in the UK, 4,450 children and young people under 25 are diagnosed with cancer. It's 12 children and young people every day, somewhere in the UK. It's around 4 out of 5 of those children and young people will survive for 5 years or more. But when you are the parent of a child, a survival rate of 5 years or more seems quite minuscule. Most of us would expect our children to be surviving an awful lot longer than that. So that survival rate can seem quite hard, which for those of us who've had adult cancer, we're quite often thinking, oh, good, 5 years, I'll be still around in 5 years' time. That feels like a success. For children, not so much. And cancer that remains the biggest killer of children and young people by disease in the UK under 25. Now, that's quite important. One of the reasons that's now the biggest killer is because other diseases have now declined, and that's a good thing. But these cancers are still affecting many children, and we would like that number to decrease, the number of children surviving to increase, the number of children being diagnosed earlier to increase. And so what we, and I say we, is the all-party parliamentary group, and the Minister will know because he was very good to that group and has worked with us closely, that we want things to be better, and we understand that this small number of children, and because of it being a small number of children, it can often be difficult to identify some real specifics that will make a big difference. But also we think because it is a small number, some of the things we want could be relatively straightforward to do. And so last year we had an inquiry into young people's experience of childhood and young adult cancer. And we would like, what we're calling on the government to do and the NHS long-term plan to do, is to look at the impact of a young person's route to diagnosis. Because recent research by Click Sargent found that over half of young people had to visit their GP at least 3 times before their cancer diagnosis. Katie, the young woman in our inquiry, who was one of our panel members, talked about this, about the fact that because childhood and young people's cancer is so rare, GPs were not expecting to see it, and therefore signs and symptoms were frequently misunderstood. I have the greatest of sympathy for GPs and clinicians, and therefore, because it's so rare, we would like there to be a training and e-learning module for healthcare professionals, and Click Sargent and Teenage Cancer Trust have teamed up to create such a one on the signs of cancer in children and young people. It's been developed in partnership with the Royal College of GPs, and we would like to see, and I would like the Minister to respond to this in his summing up, more support in the NHS workforce for recognising those signs, whether it's using that e-learning module or something different, whatever it is. Because the NHS long-term plan published yesterday, I was really pleased to see a specific mention of childhood cancer. However, I was disappointed that there wasn't more emphasis on skilling up the healthcare workforce on recognising those signs and symptoms. Because, as we all know in this room, the consequence of failing to make a diagnosis early is often that survival rates will be very poor. So in our inquiry, we also recommended many things which the Minister has very kindly agreed to go through with his officials and respond to us about in some detail. So I'd like, in his remarks, or perhaps after this debate, if the Minister would perhaps liaise with my office about when we're going to make that time to meet, because I am grateful to him for his willingness to do that, but we'd like to make some progress in the first half of this year. And some of our recommendations that are relevant to this debate are that the Secretary of State should ensure that, for education, should ensure that every young person receives some health education, which includes cancer signs and symptoms, done in an appropriate way. And the Teenage Cancer Trust have developed a module for education, which many of us will have seen recently when they demonstrated this in Parliament. I would like to see something like that. Yes, I'm happy to give way to my friend.
Thank you, for making an excellent case around the education point. It was something that I want to raise as co-chair of the breast cancer APPG, which was around the fact that around 3,500 breast cancers go undetected each year due to women not understanding the risks due to breast density. And education would seem critical as part of that long-term plan to actually, if we're to get those world-class outcomes, that people actually understand the personal risks that they face.
Yeah. I thank my friend for that intervention. He's absolutely right, and I think education is critical across most, perhaps all cancers. Breast in particular, I think there are many young women who need more understanding of how their risks can be reduced based on certain lifestyle choices. And I say that carefully without wishing to blame survivors of cancer, because it's a difficult balance. But education is important, because I think the health service that we want for the 21st century is one that's about health rather than about sickness. And what I wanted to see in the NHS long-term plan was more emphasis on prevention. And I would like, in his remarks, if the Minister in his summing up could address some of those, because we think in the all-party group that an emphasis on prevention is critical for young people's long-term survival and long-term health, not long-term sickness, long-term health. We are concerned about the shortage of radiographers and radiologists, but others will make more remarks about that. And so I want to conclude by saying that if we want more children and young people to survive, please, longer than 5 years, early diagnosis is absolutely critical. Health professionals will perhaps see only one childhood cancer in their entire professional lives, so they're going to need help. I would like the Minister to talk to us and to his officials about how we're going to help professionals to do better on that. And we would like to see more education of young people across a range of cancer indicators and a range of ways that changing your lifestyle, introducing exercise, reducing alcohol, all those things we all know, quite often too late, but we could do with knowing them from an early age and building them into our way of life from young people onwards. I'd like the Minister to address that in his final remarks. And I'd also like to conclude, without getting too emotional, by paying tribute to Click Sargent and to Teenage Cancer Trust in particular, who do so much, not just for children and young people, but for parents and families. My own family received help members of my family received help from Click Sargent, and my dear sister-in-law works for Click Sargent and has been an inspiration to me on childhood cancer. And I would like to see the work that they have done embraced by other ministers, other than this minister, who I know already does, and taken forward into the NHS long-term plan. Thank you, Mr Howarth.
Lloyd.
Thank you, Mr Howarth. It's a privilege to serve under your chairmanship. I'd also particularly like to thank the honourable member for Popular and Limehouse for securing this debate.
It's a very, very important debate. I'll keep my remarks brief because I know there are quite a lot of people who want to speak. So, Mr. Chairman, I'd like to focus on one particular area of early diagnosis, and this is to do with bowel cancer, and there are two reasons. Firstly, for those who don't know, bowel cancer is the fourth most common cancer and also the second biggest cancer killer. Yet bowel cancer is not only treatable but curable, especially if diagnosed earlier. The Minister will know that ever since my re-election, I've been pressing him and the department hard to reduce the bowel cancer screening age in England down from 60 to 50. I was delighted a few months ago that the Minister concurred and agreed to that and announced that the reduction would be taking place. I'd like to pay tribute to a constituent of mine, Lauren Backler, who first started the campaign for the reduction in the age limit 3 years or so ago. Sadly, her mother died in her mid-50s. It's very likely her mother wouldn't have died if she had lived in Scotland and had the early diagnosis. This prompted Lauren to launch the campaign, and it's been an unbelievable success. In numbers alone, over 500,000 people across the country have signed it. I and colleagues in the room have been campaigning avidly for it for the last couple of years, and the Minister and the Department of Health announced it a few months ago. Yes, of course.
Thank the honourable member for giving way. He will be pleased to know that in Northern Ireland, with the bowel cancer screening, from the introduction of the screening kits, we have now 60% participants, and we've reduced that. So it's a fantastic result in Northern Ireland, and I think we need to do more of it.
I thank my honourable colleague for his intervention. He's very right. The introduction of the new FIT kits, FIT, will make a huge, huge difference. The reason, though, that I'm standing up in this debate is that, as the Minister will know, and as one or two other people have alluded to, in the announcement yesterday, there's still been no clear announcement about additional staff and capacity to ensure that the bowel screening age is brought down from 60 to 50. I commend the government for listening to Lauren, the hundreds of thousands of people across the country, and myself and colleagues in the room for reducing the age, because it's quite clear statistically that lives will be saved, many thousands in fact. However, I was anxious that there was no announcement yesterday about the additional budget that's going to be required for the new staff and actually a plan for it to happen. So I would be very, very keen to hear from the Minister in his roundup, not just the words that say the Department of Health is behind it, but actually detail of when that announcement will be made about the capacity for the additional staff. I would particularly urge that because, as the Minister knows, the budget decisions are going to be made in March and announced in March. So I really would like to see some flesh on the bones from the Minister. This is one of those issues where we know we have a solution. We understand in this room that there are capacity issues and finance issues. We applaud the government and the Department of Health for actually publicly stating that they're going to bring down the age limit. What I need now, what we all need now, is just flesh on the bone and detail. So Lauren Backler, my constituent, and her remarkable, remarkable campaign in tribute to her mother can actually see, frankly, within the next few months, the first rollout of this age reduction in screening for bowel cancer. Thank you.
Dakin.
And I congratulate my honourable friend for securing this very important and timely debate. We very much welcome the NHS long-term plan, and it's a once-in-a-generation opportunity to significantly improve cancer care in this country. The plan rightly recognises that one of the biggest actions the NHS can take to improve cancer survival is to diagnose cancers earlier, and sets out welcome commitments to radically improve early diagnosis. I hope that as the plan develops, there will be more specific plans for the less survivable cancers, pancreatic, brain, lung, stomach, liver, esophagus, that make up over 50% of all cancers. Mr Howarth. I was pleased, as chair of the All-Party Group on Cancer, to chair the Britain Against Cancer Conference last month, which focused on future priorities for cancer care. There were many reasons to be cheerful, Mr Howarth, but one of the big issues of concern was around workforce and whether there will be sufficient workforce to deliver the care that is needed in the future. And there is still a lack of clarity around this, despite the efforts in the long-term plan. So it's useful to have this opportunity to focus more on it. As we know, the number of people being diagnosed with cancer in the UK is increasing, and the changing needs of cancer patients also presents a challenge for the professionals working in cancer care who are dealing with rising caseloads and increasingly complex needs. The plan's ambitions to diagnose 3 in 4 cancer cases at the earliest stage by 2028 is very, very welcome. However, unless we have a plan to address current staffing shortages backed up by significant investment, the NHS will struggle to maintain today's standards, as other honourable members have already said. In NHS North Lincolnshire, CCG, my area, only 71.9% of patients receive their first cancer treatment within 62 days of an urgent GP referral. This is well below the England average and also below the national average of 85%. These delays to cancer waiting times are often caused by a diagnostic bottleneck, Mr Howarth, not having enough capacity to carry out the tests needed to confirm a cancer diagnosis so that patients can begin their treatment. So I very much welcome the announcement of capital investment for North Lincolnshire and Goole Hospital Trust just before Christmas in diagnostic equipment for both Diana, Princess of Wales Hospital in Grimsby and Scunthorpe General Hospital. And they will make a significant difference, I hope. But in order to improve early diagnosis and match the best cancer outcomes in Europe, it's crucial that we have the workforce in place to support growing patient need. Whilst the NHS long-term plan sets out ambitions for the future workforce, the funding available for additional investment in the workforce in the form of training, education and continuing professional development through the HEE budget has yet to be set out by the government. So will the Minister, who's an excellent minister, set out when this budget will be confirmed and if the government intend to set out further funding arrangements as part of the comprehensive spending review? NHS staff shortages in both primary and acute settings have been consistently highlighted by organisations in the sector in recent years, and there's an urgent need to grow the cancer workforce. Indeed, Cancer Research UK estimate that the cancer workforce needs to double by 2027, and similarly, Macmillan has seen estimates that the supply of adult nursing must increase by 45% in the next 10 years. These are big numbers, Mr Howarth. Macmillan's workforce census last year highlighted considerable variation in vacancy rates for cancer nurse specialists across the country. This is also seen for specialist chemotherapy nurses, with vacancy rates as high as 15% in some areas. A recent survey of healthcare professionals working in breast care in hospitals by the charity Breast Cancer Care paints a worrying picture, with 87% of respondents stating that there are job shortages in their hospital which could affect breast cancer patients. A Freedom of Information request from the charity found that 2/3 of hospital trusts in England don't provide a dedicated nurse for people living with incurable breast cancer. Given this, it is crucial that a fully costed plan is produced which demonstrates how the health and care workforce will be sustained and grown. The long-term plan states that there will be a separate workforce implementation plan in 2019, but more detail is needed about these timeframes. So it would be helpful if the Minister were able to set out when that implementation plan will be published. And I'm not sure that soon is quite good enough. We'd like a date, please. The 2015 Cancer Strategy also recommended the publication of a cancer workforce plan, yet the sector is still waiting for the publication of Phase 2 of the plan by Health Education England. Will the Minister outline how the implementation plan relates to the long-promised Phase 2 HEE plan on the cancer workforce? If the ambitions of the long-term plan and the 2015 Cancer Strategy are to be realised, we must see a comprehensive, fully funded workforce plan which sets out how the cancer workforce can be upskilled and developed to meet the growing needs and numbers of people living with cancer. Thank you, Mr Howard.
Well, to Shannon.
Thank you, Mr Howard, for calling me. First of all, can I thank the honourable gentleman for Popular and Limehouse for bringing it forward and thereby giving us all an opportunity to participate in a debate which we all feel is very, very important. I'm also the party's health spokesperson here, so therefore health issues come to the top of the tree in interest. Pleased to see the Minister in his place and the Shadow Minister there as well to respond to our concerns. The Backbench Committee very kindly granted this debate, and we appreciate that. Cancer is a word that I hate. It's a disease that I hate. A respecter of no person. It indiscriminately attacks and takes from us those we love and rely on. I truly believe that there must be a cure found, and found soon, for this dreaded disease. And whilst this work is taking place, we must focus on the best use of the limited resources available. Well done to the Government on their NHS 10-year plan that they brought forward yesterday, and their commitment to a cancer strategy within that. When some of the honourable members who have spoken so far have referred to family members and friends who have been stricken by cancer, and we all have those. I have a very good friend who's going to have some breast cancer surgery on Friday coming. I'm also very conscious that my father was a person, Mr Howard, who survived cancer on 3 occasions due to the expertise of the surgeon, the nurse's care, and very critically to the prayer of God's people. Bowel cancer, the honourable member for Upper Ban referred to the bowel cancers kit that they have in Northern Ireland. I probably because of my father's history, do that screening and that kit thing every year, and thereby know if there's any detection of cancer early on. So that's what we're doing in Northern Ireland, and that's hopefully something that other parts of the United Kingdom can take on board. Absolutely, yeah.
Thank you, Honourable Member, for giving way. Would you agree with me that given the almost universal acceptance of the importance of early detection rates rising, that this long-term plan, as any other health long-term plan, will be judged against that rise in early detection, because that, crucially, is the key?
Thank the honourable friend and colleague for that intervention, and I agree wholeheartedly with what he's just said. Many more people are dying due to cancer, but a larger number of people are surviving their cancer diagnosis, and that comes back to the point that my honourable friend has said, and I support that. I want to, if I can, just pay some thanks to the tremendous staff who work well above their pay grade and hours to make a difference to the quality of care and the support for cancer sufferers. I also wish to put on record my thanks to the wonderful charities who aim to step into the breach where at all possible. And we all have charities, and by not mentioning some of them today doesn't mean that they're any less important, because there's so many. Yeah. With cancer care, with the Marie Curie who do tremendous work, but we also have, and I want to speak about one in particular if I can, and that's the amazing charity Macmillan, who by the year 2017 had over 5,700 Macmillan nurse posts supporting some 658,000 people. There were a further 2,000 healthcare professional posts throughout the United Kingdom, and in 2017 1.6 million people received personal high-impact support for one or more Macmillan professionals or services. Again, that's what Macmillan does. Whilst broadly welcoming the government scheme, Macmillan have expressed, and just to have it on record, Minister, have expressed serious concerns that the plan does not adequately address the immediate and long-term pressures facing the NHS cancer workforce. And these are put forward in a constructive fashion, and it's meant to be that way. The NHS long-term plan makes clear that the funding available for additional investment in the workforce in the form of training, education and continuing professional development through the HEE budget has yet to be set by government, so they're quite keen to have it done. This is a key priority and must be urgently addressed. The plan states that there will be a separate workforce implementation plan in 2019, but more detail is needed about the timeframes and how the implementation plan relates to the long-promised Phase 2 HEE plan on the cancer workforce. I believe it's essential that we build on the ambitious foundations of the NHS long-term plan and put in place a fully funded strategy for the workforce that would truly deliver world-class cancer care. So that's a quotation from the Macmillan and what they put forward for this debate, and I wish that maybe the Minister can respond to that, please. I agree with these sentiments as expressed by Macmillan. I further agree that more detail is needed to address the funding gaps to address the issue of speed of diagnosis in quick-moving cancers such as pancreatic cancer. The Honourable Friend for East London Derry referred to early diagnosis. The Honourable Lady for Bristol West referred to early diagnosis. And I think nearly every member who has spoken so far has said early diagnosis is really critical, and so it is. Pancreatic cancer is the quickest killing cancer, with 1 in 4 people dying within a month. Therefore, we need a faster pathway to diagnose and treat pancreatic cancer. An honourable member for Scunthorpe, who is particularly interested in pancreatic cancer, will know that to be the case. Early diagnosis is essential for pancreatic cancer, as it offers the only chance for potentially curative surgery. However, less than 20% of people with pancreatic cancer are diagnosed at an early stage, and less than 10% will receive surgery. The capacity for this does not currently exist. There must be an increase in the cancer workforce to ensure timely diagnosis and treatment. Therefore, Macmillan's point of view, which I think has been supported by every member in this Westminster Hall debate today, is critically important. Prostate cancer. One member has referred to prostate cancer. It's again, men by their nature, whenever we're ill, we're the illest people in the world. But sometimes we just don't know when we are ill. And the point I make in relation to prostate cancer is because we don't do the checks, and we all know what has to be done. You check yourself. If you're more frequent to the toilet, if you have a burning sensation, if you have passage of blood, those are just some of the symptoms. But men perhaps need to look out more for that. And maybe when it comes to prostate cancer, I think we need to raise awareness. I think government does that, to be fair, but we need to perhaps maybe do more. The view is further underlined by the wonderful, and I want to make a point, and I forgive me for repeating some of the comments, but I think it's important. The Honourable Lady for Bristol West referred to Click Sargent, and I want to make some comments about children's cancer. In my conclusion, Mr. Harris, the view is further underlined by the wonderful charity Click Sargent, who have asked me to use this opportunity to stress something that shocked me when I first read it. Children make up the highest proportion of cancer patients that are diagnosed through emergency admissions. That's when it first becomes aware, and many young people and parents have a poor experience of a diagnosis. The best chance from the start, that research report on experiences of diagnosis 2016 found that over half of the young people and almost half of the parents who visited their GP at least 3 times before their cancer diagnosis. So therefore, there's a real need, and the member for Bristol West referred to a real need to have that early diagnosis for children in particular. Nearly half of young people felt that their GP did not take their concerns seriously. I don't think that's a criticism, it's how they felt. And a third of parents felt that their GP did not take into account their knowledge of their child. So we can't ignore the knowledge of the child of what the parent is saying. So therefore, when it comes to raising awareness with GPs, I think it's really important when it comes to children that something is done. Just over a third of young people and a quarter of parents felt that their GP did not have enough time to listen to them talk about their symptoms. So, Minister, what's been done to address that issue? Ever mindful that the GPs are under pressure, they're highly, they have a lot of work to do, but I think the parents and the children who are diagnosed with cancer early really need to see something happening there. So I would request something in that, as the Honourable Lady for Bristol West referred to as well. These are factors which must urgently be changed, and this can only be done by funding to take the pressure off diagnostics, to allow GPs to refer before their 3rd repeat visit. GPs must be allowed to go with their gut and send anything suspicious to be tested further, rather than playing a numbers game and a probability game. Cancer does not respect the numbers game. It strikes at all the most unexpected times amongst the people who are less expectant to have them. Last paragraph, Mr. Harth. Time has beaten me. But whilst I heartily welcome strategy, we need more detail, and we need more action, and we need it soon to make a difference, to make a worthwhile attack upon the plague of cancer and families throughout the United Kingdom. And that's why this debate today is so very important. Thank you.
Charalambous.
It's a pleasure to serve on your chairmanship. I want to start by congratulating my honourable friend, the member for Bowen Popular and Limehouse, for securing this very important debate, very timely debate. Lives are saved when cancer is diagnosed early. And I know that we're all united in wanting all cancers to be caught early so that survival rates can be drastically increased. But to diagnose and detect cancer early on, we need sufficiently skilled and fully staffed workforce. Our NHS staff do amazing work, but they're under extreme pressures. We are one of the richest countries in the world, but lives are being lost because of underinvestment in our NHS workforce. If we're to come anywhere near achieving the Prime Minister's target to diagnose 3 in 4 cancers at their early stages by 2028, we'll need to have a long-term plan that will deal with the staffing shortages, which will no doubt get worse post-Brexit. Cancer research estimates that by 2035, 1 person every minute will be diagnosed with cancer. At present, 9 out of 10 people will survive bowel cancer when diagnosed at an early stage. But that figure reduces to only 1 in 10 if not diagnosed until stage 4. Currently, only 46 to 61% of cancer sufferers are diagnosed at stage 1 or 2. And this means that people are slipping through the net and needlessly dying due to the lack of resources. And with 40% more people being referred for diagnostic cancer tests than 4 years ago, we know that cancer diagnostic services are struggling to keep up with demand, as they've already missed their cancer waiting time targets over the last 3 years. As the co-chair of the APPG on breast cancer, I'll now focus the rest of my comments on breast cancer. For breast cancer, the situation is even worse. The breast imaging diagnostic workforce are absolutely critical for the early diagnosis of breast cancer. But Breast Cancer Now have discovered that only 18% of breast screening units are adequately resourced with radiography staff to meet demand. And taking into account the ageing workforce of breast imaging radiographers and the increase in demand, and you have exacerbated pressures which will only get worse. For every 3 breast radiographers that retire over the next 5 years, only 2 are expected to replace them, which will mean that imaging and diagnostic services will be unable to keep up with demand, thus causing delays which will in turn cause greater anguish for those waiting to be tested. 55,000 people are diagnosed with breast cancer in the UK every year, and yet survival rates lag behind Sweden, Portugal, Germany and France. We have a declining workforce and an increase in demand. Unless the government invests in a fully funded workforce plan, patients will suffer. We need a new approach to workforce planning based on best practice and clinical need. Health Education England must produce Phase 2 of the Cancer Workforce Plan, which looks at how many staff are needed to meet the growing patient demand and set out a 10-year cancer workforce strategy. This plan must be backed with appropriate funding. Breast Cancer Now have also called for the government to invest £39 million in the recruitment to the breast imaging diagnostic workforce as part of this plan to cover the cost of training and fill clinical radiologist vacancies and to address the current shortfall of radiographers. The government's decision to scrap bursaries for allied health professionals and nurses is also a factor that's making it harder to recruit. To become a mammographer, you must self-fund an MSc following a 3-year radiography degree. Prior to the bursary cuts in 2017 to the allied health professionals course, including diagnostic radiographers, the undergraduate degree was covered by a bursary. Following this disastrous cut, there was a 20% decrease in the number of applications to the Allied Health Professionals course, and a further 9% cut in 2018. This under-resourcing directly linked to the government's bursary cuts has undoubtedly cost lives. I'd urge the Minister to reverse this cut to bursaries and ensure that the financial barriers to becoming a mammographer are removed and more applicants are encouraged to apply for the Allied Health Professionals course. Funding for early diagnosis is not just about staffing levels and recruitment, it's also about new technology. There are new improved ways of detecting breast cancer, such as via tomosynthesis, which is far more effective in detecting breast cancer in some women. Artificial intelligence could also be used to assist in analysing the vast data capture involved in screening, but this requires commitment of investment in new technologies and training by the government. Risk-stratified breast screening is another way of making better use of technology to assess a woman's individual level of risk by using algorithms to assess various risk factors. Once assessed, a more personalised service can be made for those women at higher risk, which could again save lives. I'll finish by asking the Minister whether he will commit to getting Health Education England to produce Phase 2 of the Cancer Workforce Plan, which will be based on need and confirm that it will be properly funded, I also asked the Minister whether he will reverse the cuts to the bursaries for the Allied Health Professionals course and nurses and make sure that recruitment levels are up to the levels that are required, especially with Brexit looming. And finally, I'll ask the Minister to commit to exploring and funding new technologies and training that will help detect cancer earlier, will target those who are at higher risk and alleviate the pressures on the workforce. If the government doesn't get the shortfall in funding for early diagnosis and the cancer workforce right, then some people will inevitably die an avoidable death from cancer. Thank you.
Thank you very much, Mr Howarth. It's a pleasure to serve under you. And I too would congratulate the member for Poplar and Limehouse on organising this debate. It is slightly a pity that it's less than 24 hours after the publication of the long-term plan, but people seem to have done lots of fast reading last night. Now, like others, I welcome the plan and particularly the extra funding to the NHS. But it's important to remember that what this brings it back to is 3.4%, which was the average over many years, indeed below the average over many years prior to 2010. And as the Secretary of State highlighted yesterday, with 1 million extra patients, this means that the money per head of population is actually going down. And it's something that should be looked at because it's a much better comparative measure. In Scotland, we spend £163 a head more on health than here in England, and £113 a head more on elderly social care. One of the things that we know, if we don't fix the social care side, then unfortunately any money put into the NHS is hemorrhaging out in elderly people trapped in hospital where they don't want to be. Again, we see the money focused on NHS because that sounds good to the public. But further reductions in public health, despite all the talk in the plan about prevention. And that doesn't make sense. Now, I welcome the every contact count. But in Scotland, we've had make every contact count for years. And as a breast cancer surgeon, I've discussed with all of my patients issues around smoking. Because they inevitably ask, why did I get breast cancer? Now, we don't have the answer for that, but we do have the answer for the majority of lung cancers. And I don't make them give up immediately when they're under stress, but I get them to promise me they will do it long term. And quite a number of them do. But I don't have time to support them through that journey. You still need smoking cessation services to which you can refer them. And they are being cut. And that is a problem. In the plan and in the Secretary of State's letter that he sent out yesterday, we again have a focus on cancer, which of course as a breast cancer surgeon of over 30 years, I welcome. But in his letter, while he talks about early diagnosis, he doesn't talk about prevention. And yet smoking is still the biggest cause of cancer, and obesity is chasing it up as a close second. We need to tackle childhood obesity, and we need to put in a 9 p.m. watershed for advertising foods that encourage that. Now, half of us will get cancer, and as has been said by all the honourable members, early diagnosis is crucial, and particularly avoiding being diagnosed as an emergency admission. That tends to have a very poor outlook. Now, for symptomatic cancers, it is important, as the member for Shannon highlighted. Oh, I keep saying that. The member for Strangford. It's because Shannon's another body of water in Ireland. I always get mixed up. I think we'll just change it. You can be for Shannon. As the member for Strangford said, you know, it is important to know the symptoms, but both the public and indeed sometimes GPs are too focused on what are late symptoms. Weight loss, jaundice, even for some cancers, bleeding is not early enough. And we need to educate people. And what we've done in Scotland is use humour. And at the moment, there's a testicular cancer advert going on around Christmas, talking about baubles and men's baubles. And I don't care what kind of humour you need, whether it's toilet humour for bowel cancer, talking about boobs for breast cancer. If it gets people talking about it, it makes it easier for people to come forward. An audit we did many years ago in Scotland, looking at the whole patient pathway, showed that for particular cancers, and bowel cancer was one of them, actually the longest step was from the first sign or symptom to even going to the GP. So while the plan talks a lot about the pathway after going to the doctor, there's only a couple of lines about educating the populace about what to look out for, and that means we have to get people talking about it. In Scotland, we've had bowel cancer screening starting at 50 right from the beginning, and I am very sorry the member for Torfen, who's no longer in his place, obviously losing his mother in her 50s, and of course in the last year or so we've had celebrities diagnosed late with bowel cancer who might well have been picked up by having the bowel cancer screening starting at 50. Now, I welcome that last August the government committed to making that change, but neither in any announcements nor in the plan is any discussion about when it will change to 50. Now, I have to say, when I turned 50 and the poo in the post envelope landed on the mat within 2 days, I found it a bit harsh. And as my birthday's Christmas Eve, I got another one last week. And, you know, I wouldn't mind if they were a bit more sensitive, but it is something you have to do. And in Scotland, we've already changed completely to the fecal immunochemical test, which only involves one sample. And what we've already seen is an almost 10% increase in uptake. And this is, again, something the government have committed to. The rollout has been commenced. But when will it be complete? Now, what's important is to be prepared for the impact that that will have on your NHS system. If you are dropping the starting age for bowel screening from 60 to 50, you are talking about a 2/3 increase in your screening population over what you have now. If you see the same 10% increase with FIT, those two together will be an almost 3%, 3/4 increase in the colonoscopies required. And therefore you have to be prepared with endoscopists and, as was mentioned earlier, by pathologists who will actually analyse the samples that are taken. Because in Scotland we've seen an increase in our waiting times for colonoscopies just with a change of FIT. So it's important to be prepared. And it's similar when we're running public education campaigns. They're no use if it's just an intense campaign. Because what we found in Scotland when we did our first Detect Cancer Early is the breast cancer units across Scotland, when we audited them, had a doubling in referrals, but actually not a significant change in cancer diagnosis. Because women are pretty breast aware. But you actually need to trickle those adverts throughout the year, or else the chances are there still won't be an advert when someone is sitting ignoring a symptom. Now, the other workforce, as well as endoscopists and pathologists, is radiologists. And not all radiologists can be identified as cancer radiologists. They will find cancer in all sorts of parts of the body. But this diagnostic workforce is critical. If you look at the waiting time performance all across the UK, people are struggling, particularly with the 62-day target, which in England has now fallen below 80%. But everyone is struggling with it. Yet when you look at the 31-day, which is from diagnosis to treatment, in actual fact, most cancers are over 90, and indeed most of them over 95%. So once the NHS knows you have cancer, the pathway is relatively swift after that. But it's this long gap to being diagnosed. And obviously in my own specialty of breast cancer, radiologists are critical for the initial test and investigation and follow-up. And for every 3 breast cancer radiologists who will retire in the next 5 years, they will only be replaced by 2. And the problem is breast screening came in around 1990. So all of these young consultants were appointed at almost the same time. And sadly, they're all retiring at the same time. The Clinical Radiology Workforce Report showed that the UK has a 1,000 shortfall at the moment of full-time radiologists, which will grow to 1,600 by 2022. 116 million is being spent on outsourcing and overtime. So this isn't even money, because that money would actually fund 1,300 full-time radiologists. It's we don't have the workforce. And yet in the plan, what we see, health education, again, over recent years, having had their funding cut despite grand statements of all the extra nurses, radiographers, allied health professionals and doctors who will be trained. The plan talks a lot about IT, but instead of focusing on digital GPs, it should be focusing on internal IT. We've had electronic prescribing, referral and response letters for years in Scotland. And one of the things we do have that can help with the radiology shortage is the PAC system, where imaging is shared right across Scotland. Every hospital uses the same system. And that means is if one place is short of radiologists or is very rural, an image can be sent hundreds of miles to be looked at for someone else. The plan talks about generalists, and that is needed, but you also need specialists. So the workforce plan is critical.
Mr Howarth, and it's a pleasure to serve under your chairmanship this morning. And I have to say it's a bit cold in here as well, just in case anybody wonders why I might be shivering a bit.
It's a very warm atmosphere.
Oh, good, yes. We do try. I want to start by congratulating my honourable friend for Poplar and Limehouse for securing this important debate and very timely debate, and for his excellent speech. I do wonder whether he's got a crystal ball and knew something that we didn't know, but I'm sure if he has, it'll be very much in demand, because I think we've got an important vote next week, so somebody might want to have a borrow. I also want to thank all of other honourable members who've spoken this morning, the members for Westmoreland and Lonsdale, Easington, Bristol West, Eastbourne, Scunthorpe, Strangford, Enfield, Southgate and Central Ayrshire, all for their excellent contributions to this debate. As we know, the long-term plan was launched yesterday, and we had waited several months for it to be published, and after a few setbacks and delays, but I'm pleased that we now have it and we are able to move forward. And I was also very pleased to say that cancer was a key priority within it, and I'm sure the honourable gentleman opposite played a large part in that. Cancer is very important, but it is an emotive issue. 1 in 2 of us will face a cancer diagnosis in our lifetime. That's quite a sobering thought. And I'm sure many of us in this chamber will know someone who has been affected by cancer personally. Some of us, I know, have been affected by cancer individually also. Some of us, no doubt, will have lost someone to cancer, and that was initially what led me as a new MP to join the all-party group for breast cancer, because I lost my mother-in-law to breast cancer over 20 years ago. And again, I noticed as well that there is a gathering of former co-chairs of the all-party breast cancer group, as well as the new current co-chairs of the all-party group, breast cancer group, as well as the current chair of the all-party cancer group. So once this subject sort of takes hold and catches your interest, it does stay with us for the whole of our parliamentary career, as it should, because it is so important. It's estimated that by 2035, 1 person every minute will be diagnosed with cancer. And that is why cancer diagnosis, treatment, care and the workforce should play an important role in our NHS now and in the future. The Prime Minister set out in her conference speech last September the government's ambition to see 3 in 4 cancer patients diagnosed at an early stage within the next decade. Currently, just over half of the people diagnosed with cancer are diagnosed early in England, so the government does have a long way to go in order to achieve this very welcome ambition. Early diagnosis improves the likelihood of survival, as we all know. For example, if you diagnose bowel cancer at an early stage, 9 in 10 will survive. But when they are diagnosed late, at stage 4, only 1 in 10 will survive. So early diagnosis is so important and also increases the likelihood of responding well to treatment. Target ovarian cancer, which I'm proud to say I'm the chair of, recently found, chair of the all-party group, not chair of ovarian cancer, the charity, found that as many as 1 in every 5 women in England are too ill to treat by the time they receive their ovarian cancer diagnosis. That is why awareness and screening programmes are so crucial to early diagnosis. But breast screening uptake, for example, is the lowest it has been in 10 years, with stark variations across the country. The percentage of women taking up their screening invitation within 6 months fell from 71.1% in 2016-17 to 70.5% in 2017-18. Now, that's only 0.6%, you may say, but analysis by Breast Cancer Now has found that upwards of 1,200 additional deaths could be prevented per annual cohort of eligible women if we were to increase screening uptake to the 80%, which is the current target for individual breast cancer screening units. With 500,000 people projected to be diagnosed with cancer in 2035, it is clear that we must do more to ensure that cancer is diagnosed early so that it can be treated effectively. The long-term plan says, and I quote, I'm sure everyone's read it and the Minister will be aware of it, but it says, we will build on work to raise greater awareness of symptoms of cancer, lower the threshold for referral by GPs, accelerate access to diagnosis and treatment, and maximise the number of cancers that we identify through screening. This includes the use of personalised and risk-stratified screening and beginning to test the family members of cancer patients where they are at increased risk of cancer. End quote. Now, this is great. It's all great. However, the government cannot make these improvements without improving the workforce. And the government must not be complacent about the role our NHS workforce have to play in this. As we all know and will attest to, our NHS workforce do a wonderful job every day, treating and caring and supporting us and our loved ones, as those who've witnessed it firsthand will attest to. But unfortunately, through the cancer workforce, the cancer workforce at the moment is at breaking point, as it already struggles with keeping up with increasing demand. There are chronic staff shortages across the NHS, with vacancies for 102,000 staff, including nearly 41,000 nurses. As anyone who's ever worked anywhere, when you've had staff shortages, the pressure that adds onto you as an individual is huge. I can't imagine what it's actually like for the NHS staff who are working day in, day out under these pressures when there's so much dependent upon them being able to do their job properly. Cancer Research UK have pointed to chronic shortages in the diagnostic workforce, with over 1 in 10 positions unfilled nationally. According to Breast Cancer Now, for every 3 breast radiologists that retire over the next 5 years, only 2 are expected to replace them. And I know others have already stated a lot of these facts, but they're worth stating twice. There is a similar problem with breast cancer clinical nurse specialists, with breast cancer care stating that they are an ageing part of the workforce, with 45% of breast cancer clinical nurse specialists aged 50 or above. The Royal College of Radiologists has warned of a shortage of cancer doctors, with 5% of clinical oncologist posts vacant during the course of last year, up from 3% vacancy rate in 2015. The Royal College of Nursing also warned that in England there are nearly 41,000 vacant registered nursing posts, which they predict will dangerously increase to almost 48,000 by 2023 if the government failed to take urgent action now. So the government must therefore take the issue of the cancer workforce incredibly serious, as nearly every person who's spoken in this debate so far today has also said. So will the Minister provide a progress report on the Health Education England's Cancer Workforce Plan, which was published just over a year ago? Additionally, can the Minister please provide us with a date for when he expects the second workforce plan to be published? Again, soon isn't good enough, as others have already said. The NHS long-term plan makes it clear that the funding available for additional investment in the workforce in the form of training, education and continuing professional development through the Health Education England budget has yet to be set by the government. So can the Minister therefore assure us that any workforce plan will be properly funded so that the workforce gap can be filled as a matter of urgency? The NHS long-term plan says we will complete the 130 million upgrade of radiotherapy machines across England and commission the NHS state-of-the-art protein beam facilities in London and Manchester. But staff will need to be trained on both how to use these new facilities and how to read those results. Education and training, therefore, must be high on the agenda for the second workforce plan. That must include reinstating the training bursary so that any financial burdens and barriers are removed so we can recruit the nurses we need for the future. It also means offering further training opportunities once qualified so staff can keep up to date with technological advances. Our NHS should be the most attractive employer in the country, but without the financial backing and support from the government, we are failing to recruit and retain our hard-working NHS staff. Of course, as the Secretary of State continues to say, prevention is better than cure, yet I have to say, with 96 million cut from public health budgets, this financial year... Right. Thank you.
Thank you, Mr Howard. Very decisive of you. It is quite cold in here, but the ministerial radiator next to me is doing very nicely. Note to box, must get radiator for shadow. It's a pleasure to serve under your chairmanship again, Mr Howard, and congratulations to the Honourable Member for Poplar and Limehouse for securing the debate. It's good to see him again. A Happy New Year to everybody. He has impeccable timing in doing so. I'm not sure he knew that when he put in for it, but he has great timing in getting stuff published. So if you could let me know how he managed that, I'd be very grateful. He and everybody talked about cancer survival rates, and the truth is that they have never been higher, and they've increased year on year over the last decade or so. But the reason for that is investment, of course, and policy decisions made by the last government and by this government. But as my shadow said, the real reason for that is because of the hard work of the staff up and down the NHS in our country, who work tirelessly over and above to give cancer patients the care and the compassion that they need. So I just place on record, as maybe wasn't said enough yesterday in the chamber, my thanks to them. But we're not in the slightest bit complacent about that. At the end of the day, one death from cancer still devastates somebody's life and somebody's family's life. And we know there's so much more that we need to do to ensure that we deliver the world-class cancer outcomes in England that all of us want and expect for our constituents. And the member for Poplar and Limehouse, in introducing the debate, sort of set the tone really when he talked about workforce, didn't he? And he said that was really the rock in a way around which you build the church. So I'll start with that. I mean, where we can't prevent cancer, and I'll come on to that, we must ensure that we got the right staff with the appropriate skills and the expertise to ensure that the patients receive the best care. And the NHS is nothing without its 1.3 million staff, and it's the biggest employer of trained staff in the world. So in 2017, HE did publish the first ever cancer workforce plan, and we set out ambitious plans to expand the capacity and the skills of the NHS cancer workforce, committing to 200 additional clinical endoscopists, and 200 already committed to, and an extra 300 reporting radiographers by 2021. But obviously, having set out our new ambitions for cancer in the party conference speech by the Prime Minister, and then our early diagnosis targets are set out in the long-term plan, and the survival targets that we have, we know that we need to go much further, and we know that we need to do more than that. So as the Secretary of State set out yesterday, the long-term plan is the next step in our mission to make the NHS the world-class employer and to deliver the cancer survival that we want. But to deliver on these commitments, we've asked Baroness Dido Harding, who's Chair of NHS Improvement, to chair a rapid programme of work for the Secretary of State. She will engage with staff, with employers, professional organisations, trade unions, the charities in this space, the think tanks, members in this House, all party groups, to build the workforce implementation plan that matches the ambition that is set out in the long-term plan. She will provide interim recommendations by the end of March to the Secretary of State on how the challenges of supply, reform, culture and leadership can be met, and then final recommendations later in the year around the spending review as part of the broader implementation plan that will be developed at all levels to make the long-term plan a reality. And, the announcement, I've been asked by the gentleman introduced in the debate and by a lot of people around the work of HEE and Baroness Harding. So the announcement of the long-term plan superseded HEE's plans to publish a longer-term cancer workforce plan. So they will now work with NHS England and Baroness Harding's NHSI under the plan being led by the Baroness to understand the longer work-term workforce implications for the development of the plan. As I said, March, full implementation plan published later in the year. I didn't say soon. But I can't give the House an exclusive this morning. The gentleman introduced it also talked about Sir Mike Richards' screening review. So that will make initial recommendations by Easter this year and finalised in the summer. And as it says in the plan, I just want to quote this. I think it's important to further improve delivery of screening programmes, increase uptake. And I know that my shadow is concerned about that, me too, and learn the lessons from the recent issues around breast and cervical screening, and to modernise and expand diagnostic capacity. Well, I will, but people won't get their responses. So.
I'm grateful to the Minister for giving way. Will he agree that a crucial part of success in early diagnosis is for both the NHS and local authorities and their public health budgets to have specific strategies to engage with minority ethnic communities to raise awareness of cancer symptoms and to encourage them to take part in screening programmes, and that's an essential part of an effective strategy to improve treatment of cancer in this country?
Yes, that's why this House gave all upper-tier local authorities the power to be effective public health authorities with ring-fenced public health budgets, £16 billion during the spending review period, and obviously decisions will be made about that going forward. But that's one of the reasons why we did that, because we believe, obviously, her borough will have different priorities and different demographics to mine in Hampshire. That's one of the reasons why we did that. It is a matter of statement of fact, Mr. Howard, that I'm clearly not going to get to respond to everybody's points in the short time that we've got. And I will, as I always assiduously do, respond to everybody in writing the points they've made. So I'll try and take a few themes in the minutes that I've got. The member for Easington, the member for Westmoreland and Lonsdale touched on radiotherapy. I very much enjoyed our meeting and thank them again for their work on that. The point that the member for Easington made on tariffs, I'm going to send him a note about that in more detail because I know it's something that he and his colleague are concerned about. They talked about their manifesto response, so we're awaiting publication of the new radiotherapy specification before we respond to the manifesto, which I think is an excellent piece of work, as it will address many of the recommendations that they made, and we expect this to be published very shortly. There is no commitment, I'm afraid to say, for a one-off investment in the LTP. However, it does commit, as he says, to improving access to safer and more precise medicines, including advanced radiotherapy. And it is not the final word, what is published in that document. It is a living document, and it's a document that I'll be working on while listening to all-party groups like his own. And he talked about the radiotherapy review. Well, there was a phenomenal response to NHS England's consultation, not surprisingly. Yes, a lot of them from the West Country of England, but they'll plan through that, and they know that I'm putting great pressure on them to publish their report in response to that, which I'm hoping and told will be in early 2019. The lady from Central Ayrshire, otherwise known as the member for the Irish Sea, it's a body of water, talked about prevention and smoking and child obesity and humour, and I loved her poo in the post. There's a great charity talking about men's bits called It's in the Bag, which is good in promoting testicular cancer. I think she's right to talk about prevention. I'm the Minister for Public Health and Primary Care and Prevention, and I think the Secretary of State has made prevention one of his top 3 priorities. She knows that it is a key thing for me. Yes, smoking is still the biggest preventable killer in our country today, as I said in the House last night around the SI debate. Child obesity, we have published a world-leading child obesity plan. We will consult very shortly. I'd hope to get it out before Christmas, but there's a lot else going on, and try to be honest with the House at all times that there's an awful lot else going on, and there's only so much I can get out the door at one time, but I will get the 9 p.m. watershed consultation out the door. I think it's damn important that we do that, and we said that we will, and we will. But she's absolutely right, and prevention is better than cure, and that's why, with the Child Obesity Plan and Cancer Research UK's work in that space has been very, very helpful.
Can I just remind the Minister that he ought to leave a little bit of time for the mover of the motion?
Right. Okay, well, okay, Mr. Howarth. Well, then I will have to close by saying that there is a lot of ambition in the long-term plan. That some people have very kindly said that I had something to do with that. Maybe so, but the ambition is matched by finances, and finances need to be matched by people. We understand that, we get that, but it is also about the much wider holistic approach to prevention and staff being part of that as well. So we get that, and I hope I've given some reassurances around the work that will be done with that. I will write to members with the rest of the points they raised, and I thank everybody for the incredible, passionate contributions, as usual, to this debate.
Mr. Howarth, thank you. I want to say I'm grateful to all colleagues for their contributions, which were pertinent, personal, knowledgeable, clinical. I thank the front benches for theirs. The Minister knows we all want the same thing. We want success for the Government's programme, better and early diagnosis, adequate professional staff and better survival rates. And we're here to help him.
Well done. Order.
43 seconds, quite well done.
Theresa Villiers to move the motion on the next subject.
Well done, Jim.
Poplar Limehouse.
Order. Can people leave in an orderly fashion, please?